Now, I'd like to talk a bit about using this information to see some of the expanded uses of EGG we're beginning to see. In particular, with regard into the field of obesity, with regard to bariatric surgery, we find that by applying these same principles, we can avoid complications and even prevent complications and assist in the procedural selection process. The same thing for implanting Intera pacemakers or other pacemakers. We know from the literature that if the EGG is hyponormal, these patients typically will not respond. We also know that if the patient is hypernormal, we would want to correct that pyloric malfunction first before placing the Intera, because that's the subset of patients who get worse. And of course, the patients who have normal EGGs are the ones who typically respond quite well. Same thing when we talk about reflux surgery. Reflux surgery is, like bariatric surgery, what we call a pressurization type of surgery. So by restoring the lower esophageal sphincter to often higher than normal pressures, what ends up happening is you pressurize the stomach. And if we are not careful, we do not do EGG as a preoperative evaluation in these cases, we could avoid the fact that there's functional pyloric outlet obstruction. And so by over tightening the lower esophageal sphincter and not fixing the problem with exit out of the stomach via the pylorus due to dysfunction, then you end up with increased pressure. And then these are the patients who typically will have surgery. The reflux will get better for a month or two, and then they will begin to recur again because of this overpressurization. Another area are going to be for those surgeons or gastroenterologists who are treating gastroparesis, either surgically or via G-POEM. In order to have improved patient selection and avoid procedural failure, once again, EGG will help to identify proper functioning of the body of the stomach, as well as the antrum. And as long as there is no functional outlet obstruction or there is no hyponormal activity, the patient should respond to therapy. In particular, I want to focus for just a moment on the bariatric challenges that can be helped with EGG. This is because bariatric disease is a chronic complex disease. It's a difficult clinical problem, and patient selection for the proper procedure and prediction of results is often difficult. Another important thing is that if you do EGG in the obese patient, normally in the normal population, only 20% will have a gastric dysmotility, but the obese population, 80% have a gastric dysmotility, the majority of which is hyponormal function. So they are already starting at a disadvantage. If we want to avoid complications due to gastric pressurization, and again, a gastric sleeve is a gastric pressurization procedure because they take out the low compliance fundus as well as most of the body of the stomach, leaving a very high pressure tube. If we do not recognize in advance the fact that there's pyloric dysfunction, you end up with 40% post-sleeve refractory reflux, up to 7% staple line fistulization or leakage, which often can often lead to death, if not severe infirmity, and multiple additional days in the hospital. Another question comes up is, would it help in deciding who should have a sleeve versus a bypass? So your hyponormal patients, because they don't have the contractility, which is really required for a sleeve to function, may be better for bypass. We would look at these patients as typically those that have to be converted from sleeve to gastric bypass, which occurs quite frequently. About 50% of the reason is due to refractory reflux. So subtyping of the disease using EGG may hold the key to proper selection of successful therapy and avoidance by pre-surgical identification and treatment of pyloric dysfunction, avoidance of the 40% post-sleeve refractory reflux, as well as the staple line fistulization. Why is this important? Because the bariatric surgeons are now beginning to recognize that they want to use EGG for that pre-op evaluation to avoid the unintended pressurization. And again, this is what it would look like during an EGG. We would see these patients as either hypernormal or they would have an elevated GMAT calculation. in which case you would want to treat that in advance, either surgically or with balloon dilation. This is typically what the pylorus looks like in these patients. It looks normal. And following a 1 to 2 minute dilation, the pylorus doesn't look remarkably larger. It just is slightly larger. And what you see is that hypernormal condition here goes back into the normal range with that dilation. We know from published studies that when we look at the gastric myoelectrical activity compared to patients who are normal versus hypernormal, we see significant improvements in the gastric myoelectrical activity. We also see significant improvements in the dyspepsia symptoms and other symptoms of abdominal pain and bloating and early satiety, fullness, and nausea, again, only in those who were hypernormal. And then finally, when we look at the gastric emptying, and of course, these days we're told not to look at gastric emptying any longer because it really isn't a reliable test, but we did note that the hypernormals only were the ones whose gastric emptying improved. What we did is we then created an artificial intelligence threshold value. So you no longer need to look to see if it's hypernormal only, you just really look at the calculated threshold value. And if it's greater than 0.59, then you know that this patient is suffering from functional outlet obstruction and would benefit from a pyloric therapy. How do we know this? Because when we did the study, we found that we were successful in permanently correcting this problem 93+% of the time. So finally, when we look at something like bariatric surgery and other diseases, other conditions will follow. Our primary objectives, of course, in bariatric surgery is improved weight loss, reduction of comorbidities, and acceptable safety profile, as well as trying to define the efficacy and safety thresholds in which EGG will help. So by subtyping of the disease, we hold the key to successful therapy, and pre-surgical identification and treatment of pyloric dysfunction will avoid postoperative reflux in these cases. Not only in things like bariatric surgery, but also in patients considering undergoing reflux surgery. I thank you very much for your attention, and please enjoy the rest of the meeting. Thank you.